Now the following are Dr. Robert Reid's disclosures. And the TEACH curriculum and slides were developed and compiled with funding from Government of Ontario, particularly the Ministry of Health and Long-Term Care. Contents of the slides are primarily based on evidence-based guidelines from the following three sources. These materials, as well as the verbal presentation and any discussion, set out only general principles and approaches to assessment and treatment pertaining to tobacco cessation interventions, but do not constitute clinical or other advice as to any particular situation, and do not replace the need for individualized clinical assessment and treatment plans by healthcare professionals with knowledge of the specific circumstances. Now, without further ado, I'm going to pass it on to Dr. Robert Reid, and I'm going to mute my line on this end.
Thanks very much. Hopefully everyone can hear me at this point. What I'm going to talk a little bit about this morning is really how we've gone about evaluating the effectiveness of the Ottawa model for smoking cessation that we developed here at the Heart Institute, and more specifically, I want to provide to you some new information around the cost effectiveness of this approach. We've been working very diligently to try to gather this information over the last few years, and hopefully this will be enlightening for many of you and perhaps provide a model that you might want to try to apply in some of your own programs. So first of all, we started off as a smoking cessation program working in hospitals. Our intention was really only to do a better job treating the smokers that came to hospital at the University of Ottawa Heart Institute. And so beginning in about the mid-1990s and progressing through the early 2000s, we developed an inpatient smoking cessation program in order to identify and address the smoking addiction in patients that were admitted to the Heart Institute. As a result of those efforts, or by the early 2000s, we had started to receive some funding to work with other hospitals to actually implement that. And so it's really that implemented program which we've taken out to other hospitals, which has become the Ottawa model. So one of the reasons that we got involved in this in the first place, and particularly as it relates to cardiovascular hospitals, is that smoking is a leading cause of hospitalization in Canada. And in these days of constrained healthcare costs as well, we also see that smoking is a leading cause of people being rehospitalized. And so in our opinion, if you're the CEO of a hospital, or any other kind of a health organization, and you're worried about the number of people that get readmitted to your institution, doing something about the smoking status of patients when they're actually admitted to the hospital is one of the most important things that we can do to prevent people from being rehospitalized down the road. To give you a bit of a primer on this, smoking-related illnesses account for about 10% of all the healthcare expenditures in Canada. That's about $17 billion. But more importantly, from the hospital perspective, about 20% of all current hospital beds utilized or occupied in Canada each day are occupied by current smokers. And we know from previous studies that certainly if we intervene with people at a time when they're actually in the hospital, and we call this hospital-initiated smoking cessation, that we're much more likely to be able to have them quit for the long term. But unfortunately, there have been relatively few studies that have been able to identify whether what we do in the hospital actually translates into long-term impacts in terms of health as well as healthcare expenditures, and that is some of the work that I'm going to talk a little bit about today. So essentially the key question is, obviously, we intervene with people in order to have them change their behavior and to get them to quit smoking. But really the question is, if they do that, does that mean that they're less likely to develop diseases in the future or to be readmitted for other types of things, or are they more likely to be alive later if they've actually been able to quit smoking? So many of you have heard about the Ottawa model before. I won't go into great detail about that, but generally this is really about taking a very systematic approach to identifying smokers at the time of hospitalization using unambiguous questions to identify smoking status. We ask people whether they've smoked any form of tobacco in the past 6 months. We also ask about tobacco smoking in the past 7 days. This information is documented on the patient chart so that there's information about that. Then all patients are provided with strategic advice to help them quit for the long term or to help them manage nicotine dependence or nicotine withdrawal when they're in the hospital. So even if people don't want to quit smoking, we provide assistance to them when they're in the hospital, because obviously all hospitals are smoke-free properties and people will not be able to smoke at that particular time unless they drag themselves out of bed and get themselves outside. We do routinely use pharmacotherapy for all patients involved in this program. Most often this is in the form of nicotine replacement therapy. For patients that want to quit for the long term, it's an opportunity for them to obviously experience a period of time when they are smoke-free and to provide comfort from those withdrawal symptoms. And even for people who have no long-term intentions, but rather are just simply trying to make it through this hospitalization, we use pharmacotherapy to help people, again, cope with nicotine withdrawal. And we also attach people to long-term follow-up. The evidence really is that if we're not able to get people, we're not able to follow up for them for at least a month after they leave the hospital, that probably what we do in the hospital is more difficult or is not that effective. So in the process of doing this, we go through a change management process with hospitals that involves gaining commitment from senior leadership. We do an assessment of the environment, and we have actually outreach facilitators that go out to hospitals and help hospitals do all of these types of activities. We also have an analogous program that works with primary care and family health teams. But a big part of this is looking at, what is the prevalence of smoking in this organization? How many people are able to quit smoking even before we implement a program? And then once we get into the implementation process, it's about providing training, usually revising policies, preparing supports like standard orders for pharmacotherapy, using standardized consult forms, getting smoking questions added on to intake questionnaires, and gathering data. We then train frontline staff, deliver service, and we measure results all the way along to find out how we're doing and provide that feedback to the hospital. One of the unique features of our program is that we've used an interactive or automated telephone follow-up system that automatically calls patients after they leave the hospital to find out about their smoking status. We also find out about whether they're experiencing any difficulty remaining quit, and we find out from them whether they would like to get assistance from a live nurse counselor, and this is really a triage system. This is monitored by a nursing staff, or in some cases the smokers helpline. They would then call back patients who are identifying that they need additional supports. And we have a whole variety of reports and tracking indicators that we can provide to hospitals so that they can monitor their own performance. Now, back in 2010, we published a study that looked at the effectiveness of our program in terms of its effect on quit rates. This was a meta-analysis of information from 9 hospitals in the Champlain area. And what we were able to identify is that starting before we have the Ottawa model in place, the natural rate of quitting amongst hospitalized patients, and this is measured at 6-month outcome, is about 18%. And after we put in place the Ottawa model processes, we train the staff, and we start measuring outcomes, we find that after implementation, the quit rate goes up to about 29%. So we know that this program and the implementation of the program is associated with an increase in quit rates, and obviously that's a good thing. And since 2006, we've actually reached more than 145,000 smokers in more than 300 locations across Canada with this approach. Now, what I'm going to talk about today is really some work that we've been doing recently that is looking at the healthcare and economic impacts of our program. And a lot of this work was actually performed by Carrie Ann Mullen, who's a PhD student working here at the Heart Institute, but she's also the manager of the Ottawa Model Network in Ontario and across Canada with respect to the hospital program. So the purpose of the data that I'm going to talk about today is really to look at whether was to examine the process and to determine the effects of a hospital-initiated smoking cessation intervention on healthcare utilization and mortality amongst hospitalized smokers. We've already talked about what the Ottawa model is and what the effects of that are in terms of quit rates. And what we wanted to do was to take this to the next level and to identify what are the costs associated with implementing this program, but also what are the benefits, or are we saving any money as a result of doing this? I'm just going to check and see whether people can hear okay at this particular point. So just to summarize the cost of the intervention, we've done some projections, and depending on whether we are implementing this process with specialized nursing staff or with frontline frontline hospital staff, the cost of implementing the Ottawa model is anywhere from $75 to about $97 per patient. So this is a low-cost intervention to deliver. That includes the cost of counseling at the bedside. It also includes the cost of pharmacotherapies received in the hospital. It includes the cost of the follow-up automated telephone system, and also the nurse counseling that comes along with it. So we know that the costs of implementing the Ottawa model are, again, in this particular range. So we conducted a study to identify the benefits of doing this using some data linkage. And so our study design was to look at a group of smokers that were treated in hospitals before the Ottawa model was in place, and then compare them to a group of smokers that were treated in a hospital after they had the Ottawa model there, the same hospital, a pre-post study in each area. And we used data linkage to healthcare administrative databases that was provided through ICES. And ICES is the Institute for Clinical Evaluative Sciences. They're located in Toronto at Sunnybrook. But they hold the data warehouses of all of the healthcare administrative data for hospitals in Ontario. They also have access to OHIP billings. They have access to mortality databases and so on. And so we used this data linkage to actually find out what was the fate of these patients that received or did not receive the Ottawa model in 12 different Ontario hospitals. Our participants were all current smokers over the age of 17 that were eligible for OHIP during the study, and the OHIP eligibility just relates to our ability to track them through the ICES databases. So this is just a summary of the overall design. We had a pre-implementation cohort, so these were patients or smokers that were seen in hospitals before they had the Ottawa model in place. We had about 640 patients in that cohort. We then implemented the Ottawa model in these 12 hospitals, and then we selected a new cohort of patients, and which in this case was around 700 patients. We tracked them over a 2-year period. We found out were they rehospitalized. We found out if they had a smoking attributable rehospitalization, and the examples of that would be if they've been rehospitalized for respiratory reasons, cardiovascular reasons, or cancer. We also looked at all-cause emergency room visits, smoking attributable emergency room visits, mortality, and also the projected costs of all of their health care provision over this 2-year follow-up period. We compared baseline characteristics between the groups using standard statistical tests, and what we did was for the main outcomes, which were rehospitalization and mortality, is that our main outcome was actually rehospitalization. We used competing risk regression, and this has a way of dealing with competing risks. So as an example, patients that die over the process, they're removed from the analysis because obviously once you die, you can't actually be rehospitalized. So there are ways to kind of adjust for these. And then we also conducted both unadjusted and adjusted hazard ratios, or calculated those using a variety of covariates so that we could equilibrate the pre-implementation and the post-implementation cohorts as much as possible. So just for some results to compare the demographics of or the characteristics of people in the usual care versus the intervention group, you can see that on average smokers that are hospitalized are about 52 years of age. It's about a 50-50 split between males and females. We did have some differences between groups. The people in our intervention group were more likely to be hospitalized with an AMI. On the other hand, the people in our usual care group were more likely to have a diagnosis of cancer. We also were able to calculate health utilities, which is the EQ5D score, during the time of hospitalization. But beyond that, these groups are very comparable, and we were able to make adjustments for any things that they differed on over the course of the study. So this is just a slide that shows the overall results of the study, and you can see that usual care is in the darker bar. The Ottawa model cohort is shown in the lighter bar, and you can see right away that in the Ottawa model cohort, despite the fact that this was a larger number of people, the absolute number of hospitalizations was lower. Also, the number of hospitalizations for smoking-related illnesses were lower. The number of ER visits was lower, and the ER visits for smoking-related were really not different between the two groups. And I'll just present these data in a slightly different way. So these are the curves, or the adjusted cumulative incidence of rehospitalization over the 2-year period. So what you see along the y-axis is the cumulative likelihood that somebody was going to be rehospitalized, and again, the x-axis along the bottom just shows the time in days. And what we can see is that these two curves really diverge right away, so that the Ottawa model curve is a lower curve, and the usual care group is in the solid line in the top part of the curve. And what this illustrates, I think very nicely, is that people that received the Ottawa model intervention, these smokers, were much less likely to be rehospitalized over the 2-year follow-up period, and that's why the curves diverge. And this difference was actually statistically significant. We can see that the adjusted odds ratio, meaning that we adjusted for those covariate differences between the group, it was about 20% higher rate of rehospitalization amongst people in the control group compared to the Ottawa model group. The other bar that we're showing here, this kind of vertical line, also shows what is happening at 100 days post-hospitalization. And you can see that a lot of the divergence in this particular curve for hospitalization is happening within that first 100 days. So these types of interventions are particularly effective at creating these very quick changes in rehospitalization, and a lot of it's happening early in the process. This is important because hospital administrators are often asked to report on their rehospitalization rate at 30 days or at 100 days as kind of common metrics. These are common measures of quality. And so again, the summary of this particular slide is that when it comes to all-cause hospitalization, people receiving the smoking cessation intervention are much less likely to be rehospitalized, and that's statistically significant. When it comes to smoking-related hospitalizations, as I said, these relate to respiratory disease, cardiovascular disease, and cancers. We could also see that smoking-related hospitalizations, as we would expect, are reduced, so that in fact there's a 29% higher rate of rehospitalization for smoking-related causes in people who are in the usual care group who did not receive the Ottawa model. And again, that just kind of confirms that a lot of this impact is a result of its impact on smoking-related illnesses. Looking at the whole idea of emergency room visits, we actually did not observe a difference in emergency room visits. You can see the adjusted hazard ratios up here and the unadjusted ratios. These were not statistically significant, so we did not prevent emergency room visits as a result of our intervention. And smoking-related emergency room visits were also not different. But probably one of the most important things that we identified during our study of the Ottawa model in comparison to usual care was that there was a huge impact of the Ottawa model on mortality. And this is data, this is the percentage of patients that died over the 2-year follow-up period. If you're in the Ottawa model cohort, your mortality rate was 8%. If you were in the usual care cohort, you were a smoker in that group, your mortality rate was 15%. And for those of you who are used to looking at mortality rates, this is virtually a doubling of mortality in people that did not receive intervention. And these are massive differences, and you can see the p-value is highly significant. Again, I think if we had other kinds of medical interventions that were showing this kind of an impact on mortality, they would the uptake would be immediate. It would be also, there'd be lots of expenditure to make sure that we put all these things into process. And this is just, again, looking at the curves in terms of all-cause mortality. The adjusted hazard ratio, which again reflects the relative risk between usual care and Ottawa model. People in usual care were 66% more likely to actually have died over the follow-up period. So again, a very big difference in terms of, and a clinically important difference when it comes to patient outcomes. The mean total costs, so now I'm going to shift gears and look at a little bit of the total costs of healthcare. So it looks like the Ottawa model is having an impact on healthcare utilization, readmissions, mortality. But what is happening? Are they incurring more outpatient costs, etc.? So looking at the costs that smokers were generating over time, we can see that the total costs for healthcare provision include the cost of inpatient admission, any OHIP billing either for specialist or for family medical care, ER visits, long-term care, home care, Ontario drug benefit billing, and also fee-for-service billing by physicians. And we were able to do a calculation by assembling all this data from the ISIS database that shows that over the 2-year follow-up period, patients in the usual care condition were costing the healthcare system $25,858 with all costs in. Whereas patients receiving the Ottawa model intervention were costing the healthcare system $21,781. And you can see that this represents a savings then of about $4,000 or almost $4,100 per patient. So going back to some of my earlier reflections on the cost of the program, a program that we can implement for between $75 and $95 per patient is able to save the system $4,000 overall. So just to sort of, again, conclude this part of the presentation, the implementation of the Ottawa model intervention is associated with, over a 2-year period, a 40% relative risk reduction in mortality, a significant reduction in all-cause and smoking-related rehospitalization, no difference in emergency room visits, and a reduction in healthcare utilization of almost $4,100. Just putting some of that another way and just looking at it with sort of slightly different lens or metrics, the Ottawa model costs about $20 per quitter. for us to generate. So for every $20 we spend, we get one quitter. It costs $103 per hospital day avoided. It is inexpensive in terms of avoiding deaths. It's only $803 per death avoided, $36 per life year gain, and only $68 per quality adjusted life year gain. The next steps with some of this analysis, and these are currently unpublished data, although they're being prepared for publication currently, we need to conduct a variety of sensitivity and post hoc analysis looking at different subgroups, and also the cost utility analysis will be performed as part of this. But I'm going to just conclude my presentation there by saying that I think we've been able to demonstrate that not only are these systematic approaches able to achieve changes in patient behavior, but they're also able to achieve very significant and very clinically important differences in rehospitalization, mortality, and cost of the healthcare system. And again, from a business case standpoint, this is, I think, offering tremendous value for the healthcare system. And from a ministry perspective, should be a no-brainer in terms of where we need to make further investments in the system in order to avoid consequences down the road. So I think perhaps I'll stop there and take some questions if anybody has any. Okay, so I see one question coming up here. What is the initial and ongoing cost for a hospital to implement the Ottawa model in 2014, and is there any financial assistance available for hospitals? So to answer your question, generally when we go to implement the program in a hospital, we ask the hospital to commit to providing some full-time staff assistance in order to do that, in order to assist with the implementation. And generally speaking, it depends, the number of FTE that are required to do that depend on the size of the hospital. Extremely large hospitals, certainly require probably one or more FTEs to do it, but small hospitals can do it with approximately anything from 0.2 FTE on upward from there. I think we've identified the ongoing costs. Really, they're about between $75 and $95 per patient. So if you're a hospital that has 10,000 admissions every year, probably 20% of your smokers, probably 20% of your patients are smokers. So you have 2,000 smokers that at $75, you're looking at about $150,000 to support the program overall. So hopefully that answers your question. I know that I see questions coming in about the implementation in primary care. We have not conducted similar analysis yet in the primary care setting, but certainly those analyses will be possible in the future. But you could use a similar kind of protocol in order to do that. Another question that's coming up is whether the Ottawa model is only available in hospitals. No, there are versions of the Ottawa model for both primary care as well as for community health centers. We also have versions that we're testing in specialty care clinics, specifically respiratory care clinics, diabetes education programs. We've done work in stroke prevention clinics. We're also doing work in regional cancer programs currently. And we would expect these numbers to vary depending on the patient population. But that's what we identify. I'm looking at Sharice's question, is the cost saving per patient only for those patients who quit or overall? That's the overall cost saving, so patients don't necessarily have to quit. It's available to everybody who receives the intervention. So I'm wondering if there are any more questions.
I Hi everyone, this is Tanya from the Teach Project. If anyone on the teleconference line has a question for Dr. Reid, please just push star 1 on your phone to unmute your line so that you can ask your question, and then when you're finished, just put star 1 again to mute your line. Hi, Dr. Reid.
Hi.
It's Ginny from the Royal Victoria Regional Health Centre in Barrie.
Hi, Jenny.
As you know, when the Ottawa model gets implemented, it's not the 5 elements are not necessarily uptaken by staff or the patient. So, for instance, you may have the 4 elements where you've documented on the chart and everything, but the patient refuses nicotine replacement therapy, or they don't want the tele-ask system. Did you look at any of those factors? But it's not necessarily a perfect implementation all the time. What's the strongest element of the best practice elements of the Ottawa model, do you feel?
I think that these are some of the sort of sensitivity analysis that we're going to be conducting. The data that we presented today were kind of the overall results, and we realized that even between these 12 hospitals, the quality of the implementation can vary quite considerably. But having said that, even with that variability factored in, which it was in this particular analysis, we still see these kind of impacts. Certainly the meta-analysis evidence suggests that you have to follow patients after they leave the hospital. It doesn't have to be with the IVR system. It can be by Smokers Helpline, but following people for at least a month afterwards seems to be important. Pharmacotherapy in the hospital is important, but what's even more important is whether people continue with pharmacotherapy after they leave the hospital. That would be expected to have a big impact on their long-term success with quitting. I think it's, so I would say that pharmacotherapy and follow-up, in addition, and the follow-up, of course, suggesting ongoing counseling, those are probably the 2 most important components long-term. To get good quit rates, the better the quit rates you get, likely the better impacts you're going to have in terms of morbidity and mortality. It's important to recognize that even in this group, we only had a 10 or 11% increase in quitting, but that still translates into huge impacts in healthcare utilization.
That's another question I have. Often success is not necessarily defined by everybody as a total quit.
Yeah.
Perhaps, how many quit attempts they've made since they've left, right. If there's been risk reduction.
Yeah.
I just wonder, I know with the Ottawa model, we're just supposed to look at smoking in 6 months and smoking in 7 days post-discharge after 6 months of having the program implemented. But should we be also looking at those other factors as well? Do you think that makes a difference?
Well, I think it depends on the condition, but certainly for heart disease and cardiovascular diseases, any exposure to smoke, so there's a very low threshold to kind of create health problems for smokers with cardiovascular disease. But for other diseases like respiratory as well as cancers, a lot of it is quite dose-related. So we would expect some benefit just simply by having people smoke a little bit less. I think it depends a little bit on the population that you're serving. And of course, the value of this will vary depending on, again, the underlying conditions that people have. So those other things are important. Yeah. So I think that I'm getting some questions about. If a hospital is providing OMSC, do they have to follow the clinic protocols? That may have been part of the same question, but I think that the better the quality of the implementation, the better results that you're going to see. We have been working with, we now work with about 45 or 50 hospitals across the province to implement the Ottawa model, and we've had funding from the Ministry of Health and Long-Term Care to to help with some of that. Generally, though, it does require some investment from the hospital itself. There are questions about working with mental health inpatients, and yes, we have worked extensively with mental health patients as well. I don't have a specific cost analysis breakdown on that population, but we probably don't quite have a critical mass or the numbers to kind of do that in one way. But those kind of evaluations can be done in the future. The primary care question, as I mentioned already, we do have primary care versions of the Ottawa model that are available. We do have a website called ottawamodel.ca, and if you go to that, you can get information on both the primary care as well as the hospital program. The evaluation reports, we are writing this up for peer review currently. Carrie's doing that, so we expect to have this published. We did just publish one based on some modeling studies. It was just recently published in Tobacco Control just last week. It was our modeling of what would be the impacts of this on the healthcare system in Ontario for four diagnoses: cancer, heart failure patients, MI patients, and respiratory patients. So that's available already online in Tobacco Control. Let's see, questions about why there wasn't a significant difference in emerge visits. That's a little bit, it's hard to know. Maybe there, we just don't have the numbers, or our sample size wasn't large enough to do that. I think when you start looking at sort of post hoc or secondary analyses of these data, we weren't really powered to look at those things as carefully, and so but at the same time, even the raw numbers didn't suggest big differences. So I'm not sure what to say about that. Questions about how often do we follow up patients. The automated system calls patients 8 times over the follow-up period. It contacts them 3 days, 14 days, 30 days, and then monthly up to 6 months. So those are the information that we have about that. And then for everybody that gets called by the automated system, on average, patients receive 2 live calls from a nurse counselor during that follow-up process. We have published those data previously, so there's information that's available about that. I'm just looking at if you're looking for information on the Ottawa model, we do have more information behind. We have some that's available publicly, but there's also more detailed information which is available. If you've got a login, you would have to contact our office in order to get that. Information about working with perinatal populations. We have a fairly limited amount of experience with that population. I wouldn't say none, but I wouldn't say we have a critical mass of information. I've done quite a bit of work on perinatal populations in the north and Nunavut, but they're quite different than down here, so I don't really have a good comment about that. Comment from PTCC about whether there are more emerge visits in the first year of quitting. Evidence suggests more use of the system in the first year. I don't think we saw that in ours. We're actually seeing less use of the system overall, and we didn't see any increase in emerge visits in people that were offered quitting assistance. Information on the process used to select patients for pre and post intervention for the study published in 2009. Well, when we do, as part of our pre-assessment, when we go into a new hospital, we have them select a consecutive series of patients that are smokers, and we get permission from those smokers to contact them to find out what the spontaneous quit rates are at 6 months before any program is in place, and that's just to provide a pre-program implementation assessment about what would happen if we did nothing, and then after we do the same thing. And it's really that comparison between pre and post quit rates, which becomes the foundation for doing this kind of research. And so that's how those groups were selected. They're consecutive samples of smokers that are willing to be followed. And generally, the participation rates are very high. They're 80 to 90%.
Okay, so if there are no more questions, then
okay, so if there are no more questions, then we will follow along. If you still do have questions, please feel free to type them in the chat box, and we'll do our best to get them answered after the webinar.
A link to the evaluation as well as
a link to the evaluation as well as the learning assessment 2 will be emailed out to everyone. Due to the fact that our systems will be going through some updates over the weekend, I will not be sending those links out until next Wednesday, July 2nd, and you will still have a week after that to complete
Our next Lunch and Learn webinar will happen on Wednesday, July 23rd.
Our next Lunch and Learn webinar will happen on Wednesday, July 23rd, focusing on tobacco interventions for patients with mental health issues. The faculty presenter will be Dr. Nadia Alim, and applications are now open through our website.
So thank you everyone for attending today, and thank you so much, Dr. Reid, for joining us.
Thank you everyone for attending today, and thank you so much, Dr. Reid, for joining us and presenting for us today. I hope everyone found it very enjoyable and informative.
Thank you.
Thank you.